Okay, this is going to be relatively short and sweet because it's really quite depressing. We're not very good at identifying genitourinary problems in the first trimester. Let's come back to the Singalaki paper, which divides the different defects up that we see in the first trimester. And you can see down round on the left-hand side, at sort of 9 o'clock, there's a fairly big bit of cheese. About 20% of the anomalies that are present in our population are renal abnormalities. The good news is that they generally, from a pregnancy and early infancy perspective, are not very significant in terms of causing lethal outcomes. But they are pretty significant later in childhood and indeed in adulthood. So the prevalence of a congenital anomaly of the urinary system or genitourinary system is about 6 per 1,000 pregnancies. About 30% of all renal pathologies have a congenital basis, and about 60% of end-stage renal failure in children is related to a congenital renal abnormality. So certainly pretty significant in that group. And I guess the other perspective on impact is that not only do they cause end-stage renal failure, but about 70% of those children become hypertensive, and that has a fairly profound effect on their cardiovascular morbidity in later life. From a prenatal perspective, probably the biggest significance is the relationship both to chromosomal abnormality and to genetic syndromes. So I think if you suspect there is a renal anomaly, I think it's very important that you consider whether it's valuable to karyotype a pregnancy properly, i.e. with an array, or alternatively whether you've done a proper survey of the rest of the fetus, trying to consider an underlying genetic syndrome. So what components of the genitourinary system do we need to examine? I guess they divide down into 4 basic ones: kidneys, ureters, bladder, and genitalia. Basically, if you can see a ureter, it's abnormal, and that's all I'm going to say about that. So that leaves us with 3 things to talk about. Kidneys, there's supposed to be 2 of them. If you think about the embryological development, it's a symmetrical bilateral process. And the interesting thing is that when that goes wrong, it can therefore go wrong in a number of ways. Sometimes a unilateral problem, sometimes a bilateral problem. Often if you have renal pathology on one side, you may have another pathology, but it could be different on the other side. So it's just worth bearing that in mind. From the perspective of the bladder, I think the most important things we can do in the first trimester is recognize whether the bladder is present or not. I'll show you that our ability to detect renal agenesis in the first trimester has been pretty poor, but fundamentally the signs are there if only we look for them. So let's just start looking at the kidneys. So this is a second trimester scan on the left-hand side. You can see a normal kidney on the left, and that's a kidney with some hydronephrosis, with some calyceal dilatation, a little bit of echogenicity around the rim of the calyces as well. So probably moderate hydronephrosis that we would see there. In the first trimester, kidneys perhaps a little bit more echogenic, and I think that makes it difficult sometimes to define whether you have polycystic kidneys or not. But I think they're quite difficult to examine in the... Oh, that's not very good. It's the go back to Australia moment. So I think it's actually easier to look at kidneys in a coronal section in the first trimester. So just a couple of examples of that. So can you see how they're reasonably echogenic? here, and that's normal. You can see here how you can examine the kidneys just with grayscale, but I think it's also often useful just to put a bit of colour on to help you define the pelvises, and particularly if you are concerned that you've got, say, unilateral renal agenesis, or that you might have an ectopic kidney. I think that's quite useful in reaching that diagnosis. So I think the anomaly that I would really like to pick up at 12 weeks instead of 20 weeks is renal agenesis. I think if you get to 20 weeks gestation and find out that you have a lethal anomaly at that stage in terms of renal agenesis, it's really very disappointing that we've not defined that at an earlier gestation. The fundamental problem is that the constitution of amniotic fluid in the first trimester is not fetal urine. So don't expect the amniotic fluid volume to be abnormal. But the bladder will be absent. Now, a bladder may be absent just as a normal process, if you like, with emptying. Remember that all of the renal anomalies are difficult, I think, to define, in part because of the fact that the volume of urine production in the first trimester is very, very low. But certainly if you're doing a 20-minute scan and you have an empty bladder at the beginning, I would anticipate that you'd at least be able to see some urine in that bladder by the end of the scan. And if I couldn't, then I would be asking that patient to come back for a proper 16-week assessment rather than waiting till 20 weeks. Obviously, renal agenesis may be unilateral instead of being bilateral, and if you think you can't see one renal moiety in the normal position in the renal fossa, then the next place to check is to go and look down in the pelvis. There's some, I think, nice new toys coming through which might help us define the shape and the anatomy of the kidney in the first trimester a little bit easier. This is just a couple of examples for you. So this is using a technique called SMI in the first trimester, so it's a low flow technique, and I think that that shows you the anatomy of the kidney quite nicely. We're about to start doing a little study just to see whether that helps us improve renal diagnoses in the first trimester. So, but I think actually for any renal anomaly, this is also very useful to be able to just define the anatomy and flow through the kidney. We find if we've got a double pole kidney, things like that, it's very useful. So I guess the other anomaly that we might talk about at 20 weeks is hydronephrosis. So you can see bilateral hydronephrosis here. In our unit, we don't typically report hydronephrosis in the second trimester. This is an example down here of one in the first trimester, but you can see it's associated with a very large bladder. Why don't we bother to report mild to moderate hydronephrosis at 20 weeks? Well, it's because if you look at this meta-analysis for markers, in fact the confidence intervals lie very close to 1 and indeed cross 1 for that as an isolated marker. So if we have done a comprehensive evaluation at 12 weeks, the overall prevalence of Down syndrome would be 90% lower than it would otherwise be. So when you take the fact that this is a very weak marker plus the fact that your prevalence of disease at that point is very low, we don't find it valuable in terms of reporting it. Turning to bladders. So as I said earlier, I would expect you always to be able to see a bladder at certainly 12, 13 weeks gestation. You can see it's quite small here. But I think the fact that you can see a bladder is important. And we do also look at the vessels in the cord, and I think that that's another useful way to make sure that systemically, when you're doing your first trimester scans, every single scan, that you are making sure that you've seen the bladder. This is a large bladder that you can see here. You can see that the urethra was dilated there as well. You've got this sort of light bulb shape. So that's probably going to be a problem related to the urethra there. You can see the hydronephrosis with that. A normal bladder will be less than 7 millimeters in length in the first trimester. There's a sort of rule of sevens, so then up to sort of 14, 15 millimeters is often described as moderate hydronephrosis. Beyond that, beyond about 15 millimeters is defined as severe hydronephrosis. The outcomes of babies with severe hydronephrosis, I would be tempted to say, is universally poor. Of course, whenever you say universally, I can anecdotally tell you about the one case where it wasn't poor. But it is associated with karyotypic abnormality and perhaps more relevant to trisomy 13 than to trisomy 21. You can see that if you have moderate hydronephrosis, certainly a significant proportion of those seem to resolve spontaneously and have good outcomes. There's a paper recently published a couple of years ago by a French group just looking at outcomes of obstructive uropathies, and they split them into outcomes by trimester, so first, second and third trimesters. And you can see that the later they made the diagnosis, the more good outcomes they had down the bottom line here. But fairly miserably, if you recognize you've got a very significant obstructive uropathy at 12 weeks, you can see first, in fact, most parents were guided towards termination of pregnancy, but second, those that continued had a intrauterine death at a later gestation. So moving to fetal sexing. So you can sex the fetus at 12 weeks gestation. The top one, you can see that the genital tubercle is rotated round so that it's running really perpendicular to the spine, or the lower part of the spine. I always say the other thing is that those little boys always have a little smile on their face at the same time. The girls, you can see that the genital tubercle runs running parallel to the lower part of the spine. And they are significantly different. At 13 weeks gestation, you should have about 90% confidence. The literature at 11 weeks gestation suggests that it's perhaps harder to be certain of diagnosis at that point, perhaps 80 to 85%. But certainly you can, I think, even on relatively old images like these here, see a very significant difference in the direction of the genital tubercle. So we use this in a study of women at risk of having children with congenital adrenal hyperplasia as one means of defining whether they needed to continue steroid therapy or not. To some extent, that's been superseded by cell-free DNA at this point in time. So from a cell-free DNA perspective, we run a contingent model at the moment. So we have cutoffs of above 1 in 50 where everybody gets a CVS and an array. For the English audience, I'm quite surprised that you've decided not to diagnose half the chromosomal abnormalities that you might see prenatally, but there you go. From the low risk perspective, we use a cutoff of 1 in 1,000 in this model, and so everybody between 1 in 50 and 1 in 1,000 we offer NIPT to. From a funding perspective, you can have your CVS in Sydney for nothing, but if you want NIPT, it's going to cost you $400. Anyway, the reason I've put that up is that as part of the process of NIPT, we do often include sex chromosomes, and if you do that, you've obviously got to be in a position to counsel people appropriately about the results that you're getting. But one of the reasons that we like to actually have a sex chromosome result is in part to help just define that the test has been done appropriately. You can see, for example, here that if you have a very low fetal fraction, that the Downs population in red and the normal population in blue coalesce at that point. And there are some tests on the market where they don't calculate fetal fraction, and from our perspective, that worries us. We've certainly seen 3 false negatives related, I think, to the fact that we don't calculate fetal fraction when we start doing this test in women who have a very high a priori risk after combined first trimester screening. So we like to just sex the fetus by ultrasound and then compare that to the NIPT result. The problem is that sometimes you get funny results, and that's because there's very significant numbers of pregnancies that actually have some degree of mosaicism related to sex chromosomes. So we have, for example, documented male fetuses with a female NIPT result, then gone on to karyotype that and find that we have a mosaic where one of the cell lines is a XY cell line. So I think there is value when you're using an ultrasound test in conjunction with NIPT to use sexing as one means of quality control. Let me go on. So polycystic kidneys, I think, are often difficult to define in the first trimester. The bottom picture is an example of small cysts, which are often quite echogenic. The top picture, you can see a big multicystic kidney there, which was unilateral in nature. And just to finish, so this is the Singalaki data on our ability to make diagnosis of renal tract anomalies at 12 weeks. So that's this column here. And you can see that the majority of diagnoses were not made in the first trimester, but were actually made at 20 to 24 weeks of gestation. And this may be one circumstance, possibly, potentially, slightly, where Gustavo's right. It's probably better to look at kidneys at 16 weeks than at 12 weeks gestation. Thank you very much.